Ladies and gentlemen, it's an honour to be introducing tonight Professor Richard Shaw, who is the Honorary Consultant in Oral and Maxillofacial Surgery at Aintree and the Royal Liverpool NHS Trusts, now known as Liverpool University Hospital Trusts. He graduated in Bristol and Glasgow. I don't know how he did it at the same time. In dentistry and medicine. I suppose they stretched it out a little bit. How many years were you at university, Richard?
Well, there was a 4-year gap between the two.
Oh, wow. So you were in practice in between?
Bristol dentistry, and then junior jobs, and then 4 years, and then medicine, 4 years in Glasgow.
Yes. I bet you're glad you're not doing it now. The student loan debt would be quite crippling. After surgical training in Glasgow, Richard moved to Liverpool in 2001 to undertake higher training in oral maxillary facial surgery, which is the same time I did it as well. I came to do peace. And he subsequently had a head and neck oncology fellowship. Integrated within this clinical training, he also managed to find time to complete a thesis as the Royal College of Surgeons England Research Fellow, and also is it a DOH? Is that a Diploma in Health or Genetics? Department of Health. One of the health. Is that one of the Clinician Scientist Awards?
No.
Advanced Sample. It's pretty good to get the Department of Health to pay for your training. And you did an MD at the Anderson Cancer Center in the USA. Appointed personal chair in 2012, Richard now co-chairs the Mersey Head and Neck Oncology Research Group, and this is an expanding and vibrant multidisciplinary collaboration of clinicians and scientists committed to improving the understanding and treatment of malignancies in the mouth, throat and larynx. Please welcome Professor Shaw to the stage.
Thank you very much, Professor Semple. And my dad was very impressed because he knows you off the telly. That chap from Liverpool's on the telly again. I said, what's he said this time? And thank you very much for the invitation, and from the Institute of Physics and the LMI, the Liverpool Medical Institution. And I guess the work that we've been doing and collaborating does meet nicely between physics and medicine. So I guess that's the rationale behind it. So I apologise for a terrible title. I've come up with a better one, which is A Surgeon, a Physicist and a Chemist Walk into a Bar, How Cross-Disciplinary Research Can Push Forward Early Detection of Oral Cancer. And I know it's a better one because I didn't write it and it won a small prize. We were interviewed on the last grant by somebody who's employed by Cancer Research UK, and that's what she came up with, having interviewed myself and Peter Waitman. And she won a little prize from the Association of British Science Writers, but she did a lovely piece. So I'm going to do something risky, and I'm going to go off on a 5-minute tangent even before I start. And I will come to physics, but it's not just delaying the point at which I start having to talk about physics and I get a look from Steve that I'm getting it wrong. It's not that. I'm going to talk a little bit about the professional context and my background, what I do for a living clinically, and how that's influenced the direction of research that we've taken. So this is just a slide stolen from Cancer Research UK about head and neck cancer in the UK. So we have 12,500 cases in the UK and a disappointing survival rate of anything between 20 and 60%. But the key thing is it's increasing with incidence, an increase of nearly 40% over the last 20 or 30 years. And the key thing to this talk is that somewhere between 45 and 90% of cases are deemed to be preventable. And that's, of key interest. Of particular interest is the fact that head and neck cancer is a disease of men. Probably 75% of cases, irrespective of the cause, occur in men. And the commonest form of head and neck cancer globally and in the UK and in Liverpool is oral cancer. And oral cancer is something that is a really difficult disease to treat because it frequently occurs close to the bones of your jaws, the top jaw and the bottom jaw. And actually I'm going to come on to James Brown, who's in the audience, who was involved in training me and as a mentor. And one of the first things he said when I arrived in Liverpool in 2001, said we need to look at reviewing all our cases involving the mandible. This issue of the mandible is key to what we do. And it took me a while to catch on because I didn't really fully understand the context. But we still see a lot of these cancers that come through our doors. We've got a big department in Liverpool, and all too frequently the management of the mandible and having to resect the mandible and reconstruct it comes to bear. And the background of this, and this is a historical picture, is that these were the results before. Our predecessors could remove the mandible, but they couldn't reconstruct it. So they left the patient with this deformity, not being able to swallow or speak or socialise, and it's a massive problem. And it was known as the Andy Gump deformity. And so I always try and learn something when I put a lecture together. So I've learnt what the Andy Gump deformity was all about. And this cartoon started about 100 years ago in the States. And Andy Gump was a kind of anti-hero and was the subject and have a family. And even, I noticed even the duck had an Andy Gump deformity. And believe it or not, the author of Andy Gump, this cartoon, whose name was Sidney Smith, had a brother who was in the medical profession and had a patient who'd had his jaw removed, and based this cartoon on this patient whose name is known. And this is a colleague of ours from San Francisco who wrote a review, and this is why I know this. And even after Sidney Smith franchised and syndicated this cartoon and made an absolute fortune, because it was all over the States, he bought a Rolls-Royce, crashed it and killed himself. And then it was such a valuable cartoon that Gus Edson continued, and this continued for, and like nobody sort of had this kind of modern woke thing, is this a very kind thing to be saying about or to representing a patient? And sure enough, this is a patient who had this surgery called David Hogue at the Johns Hopkins Hospital, and he sued the cartoon, the institute, the publication, because this is belittling, and the words are, it caused him suffering and disgraced humiliation, and he sued the publication for $1 million, which 100 years ago, I guess, was a fair bit of money. But not wishing to make light of this, I now know what an Andy Gump deformity is. In more academic terms, the problem that we got all the time was this, is that we had a problem of overall well-being, of appalling cosmesis, swallowing, function, competent speech, no teeth, can't chew, and took a long time in hospital to get out of hospital and was very costly. So evidently it was a terrible thing to do to a patient. So why I applied to come and train in Liverpool, although the architectural three graces were very important, and I have to say I didn't know James was in the audience, but this is why I came to Liverpool, is because there were three pioneer of the head and neck reconstructive surgeons in the UK, and it was known to be a good place to train. So David Vaughan was one of the earliest surgeons in the UK to use microvascular free tissue transfer. James was really quite an adventurer in taking bony flaps and doing things with them that were not done by anybody else in the world. And Simon Rogers did the quality of life and the functional outcome measurements at the end of this. And James retired formally just over a year ago. And this was our shtick, this was us. This was the regional maxillofacial unit, which now has 17 consultants. It's the largest unit in Europe, our unit in Liverpool. And I suppose I sort of went along with this and went quite a long way down this avenue of taking part in the development and academic surgery within this unit. So what they did, rather than this Andy Gump deformity, was take bits of the body from elsewhere, and they would take some bone and some soft tissue, maybe some muscle, maybe some skin, on its blood vessels, and they would reconstruct the top jaw, bottom jaw, or other parts of the head and neck, and connect these blood vessels in a way that would restore function to the patient as best possible. So nowadays, and this is in the post-James Brown era really, I can't say this is physics, but it is engineering and it is IT, and what we do is we get scans of the patient, we render them in a virtual space on a computer, and we do our operations virtually before we get the patient anywhere near the operating theatre. So this is a tumour that's been removed, and we want to redesign and refabricate the jaw. So having done our resections on the computer, what we then is move that shape accurately, in this case to the hip bone, and work out how we're going to get the same shape out of the hip bone, which will be connected to the blood vessels that come. And there is one or two surgical pictures, they're not too gory, but what we're able to do, this is the tumour here on the back of the jaw, and these are cutting guides which are 3D printed from these virtual models. They're secured by a screw, and they have drilling holes so we can pre-locate, we know where the plates are going to be. And this similarly is from the iliac crest, from the hip, the bone that we use to reconstruct the mandible, and again with pre-drilled plates. And the only thing we have to actually print the model out for is, at the moment in Liverpool, we can't print titanium because it's too expensive. So what we do is we print out the final model and we bend plates, or we get our technicians to work with us and bend plates. So we've done all the surgery in our heads and on the computer and on the models before the patient is even put asleep. So the results of this are now nice and accurate. We can start with a tumour here. You can see this faint line with the tumour involving the jaw. This is immediately after the surgery, where the iliac crest vascularized graft is put into place. And this is the final result 3 years down the line with, fortunately, in this case, a cured patient. And a more challenging patient, this lady has a tumour invading the front of her jaw, and these teeth are all loose, and this is the tumour. And similarly now in this case, in order to make the right shape, we have to sort of mitre the result. And again, we can play with various options. And these are the cutting guides that we make on the hip. And this is the plate that we bend up on our printed model. And this is our operation that's then done. And where we use the cutting guides, we section the mandible. We've got our nice mitered joint from the iliac crest with the internal oblique muscle to line the oral cavity. And this all sits into place. So how do we connect the blood vessels? Well, we do it using microsurgery. So in here carefully you can see a row of 10 or 12 microsutures, which are just a bit too small to see with the naked eye, that we spend long hours operating on. These are our current 2 fellows, and there's Tim from New Zealand and Ahmed from Egypt. We train them, and we use these venous couplers as well, and this coupler is around 1.5 to 2 millimeters across. And this, believe it or not, is quite a reliable way of reinstituting a blood supply immediately, because if you use simple bone grafts in cancer patients, it doesn't work. They fail and they get infected. So this case goes from the tumour to the immediate reconstruction to having implants and then oral rehabilitation by handing it over to our dental colleagues, Chris Butterworth, who makes a dental prosthesis on what we've done. And we get some nice results. And so I guess the highlight of this, and this was James's thesis really, he was kind enough to include me, was the paper on the classification reconstruction of the top jaw defect, and similarly the lower jaw defect we worked on together. And I suppose that's what I could have done for my career. That's my tangent over. I have a colleague in Groningen, and he's got a startup called 3D Labs, and this is what he does. He pushes the academic side, the engineering side, and he stays clinically active, and he's in my specialty. But you know, we're quite proud of ourselves with all of this, and then at a certain point, I'm going to say 15 years ago, can't remember exactly when, I was asked to talk to our cancer network lead, who's called Chris Holcomb, that some of you will know. And I thought Chris was going to call us, who were involved in head and neck surgery, and he was going to pat us on the back for doing such a good job at treating the cancer patients in Liverpool. What he actually said, and you're probably ahead of me here, is that we've got the worst head and neck cancer mortality in Britain, and we've got the worst incidence of head and neck cancer, and what are we going to do about it? We're the academics. And myself and Terry Jones, who was my counterpart in ENT, were basically told off. And sort of realised that of the determinants of health of the population, the quality of care in a hospital is a trivial part of this. It probably represents, 10% of the overall health of the population is how good treatment is, the difference between good treatment and bad treatment. And the rest of the stuff, the reason why I'm 55 and, touch wood, reasonably healthy, is all about public health and diet and nutrition, environment and love and nurture. And all those things has nothing to do with the medical profession directly in the sense. And of course we've got this huge problem in our region with deprivation, and that feeds directly into our problems with the incidence and late presentation of head and neck cancer. So we were able to divide the region up, and it's no shock, but some of the wards, and these are called super output areas by the public health colleagues, have very bad deprivation and high rates of head and neck cancer. And these were our conclusions. The incidence had increased. The peak incidence in men was as bad as anywhere in the world, including places that are famous for head and neck cancer, infamous, like India and South America. More than half our cases were coming in with locally advanced disease, needing the type of surgery that you've seen, and keeping us very busy in Aintree. And we had this regional variation in incidence that we could plot by postcode that correlated really quite directly with deprivation. So it did make me think a little bit as to why I hadn't been congratulated for training and taking part in such surgery. And I suppose, looking back, we did sort of rationalise what we're going to do and how we're going to do it. So what were we going to do? Well, we can identify areas that are really important, but to us, as academic head and neck clinicians, are intractable problems. So deprivation and poverty isn't something that we can go at. I'm not saying it's not a problem, but it's not easy for me to tackle. And smoking cessation, it's the same for all doctors, and it's probably a bigger problem for lung cancer than it is for head and neck cancer and many other diseases. But there were tractable issues. There were things that we felt that we maybe could influence, and they were in the area of patient and awareness in GPs and primary care of the problem, to get early presentation, about preventing a subset of our tumours that are caused by high-risk human papillomavirus, because at the time only girls vaccinated in the UK, and it wasn't gender neutral, but the tumours were seen in boys and in men. And then the area that I'm going to eventually come to talk about, which was oral premalignant lesions, and these patches in the mouth, which were a clinical problem. So the way we engage with these tractable problems was through the formation of Liverpool Head and Neck Centre, which the university kindly supported, which is the combination of our patients, our trusts, and this is our foyer of our elective care centre in Aintree, our outpatients building, and the University of Liverpool. And we're now located in the William Henry Duncan building, and we now have a collection which is of a broader specialty base than where we started with just academic surgeons. So we do have 4 academic surgeons, but we also have medical oncology, oral pathology, speech and language therapy, oral medicine, and we're working on other specialties such as radiotherapy and public health. But also, and critically, to develop collaborations with underpinning science. And one of the things that was never completely clear to me in the university is you could go and knock on anybody's door and work with them. And that is one of the great bonuses of academic freedom in our system. So we have very active collaborations with immunology and with cancer biology and with genomics and with physics and also with clinical trials and so forth. So in terms of GP awareness of the problem, we worked with Cancer Research UK and the British Dental Association to produce a toolkit that's been visited as an online training tool by 20,000 dentists in the country. We produced a similar version for GPs, and I just think we're too far down the list of priorities for GPs, and it hasn't been as successful. In terms of human papillomavirus, as it turns out, some data we produced both regionally then at national level, that well over half of our tonsil tumours were caused by high-risk human papillomavirus, was influential in persuading the rather stickly JCIV, the Joint Committee on Vaccination, to introduce gender-neutral vaccination a few years ago. And that became an impact case study for one of my colleagues, because really it's one of the Liverpool papers that led to that decision. So what about this problem of oral potentially malignant disorders? We have patients who have patches in their mouth and their throat and their lips, and we know these patches have a risk of transforming to cancer, so surely that's an opportunity to interrupt this and to deal with it. So dividing this problem up, thinking about it in terms of the clinical treatment of these things and where the controversies lie, in particular the prediction of malignant transformation, which cases are going to transform, and then maybe innovations in therapy. And so we have lots of patients with these lesions, and these are white lesions, these are fairly typical leukoplakias. So thinking about classification, I always think in medicine people are either splitters or lumpers. And this is Saman Marikasoria, and he's an oral medicine consultant, and like pathologist, oral medicine, like oral dermatology, they're splitters. You give them any disease and they'll divide it into 20 types and ask you to learn them. As surgeons, and I think maybe as GPs, we're lumpers. Look, do I need to operate? Is it going to harm the patient? Make it functional, make it something meaningful to the treatment. But Saman is definitely a splitter, and he heads the WHO committee, and he's based in London. And we've got all of these different types of oral potentially malignant disorders. And we think of patches and lesions, but some of them reflect a more systemic or a regional disorder, so that's why that name changed. And we have promotions and relegations from this list regularly. I say this is the sort of thing pathologists absolutely love to do. But the highlight of this list, and the most important, is leukoplakia, and I'll explain why. Leukoplakia, white patch. The prevalence, 4% of the population. So this is a summation of quite a few studies. And you think, well, what about oral submucous fibrosis? 5%. This is only in certain subsectors of South India, the Maldives, Sri Lanka, with betel quid chewing and the areca nut. So this isn't real in the whole global population. This number at 4% is high, and all the other numbers are much smaller. And the malignant transformation rate, the MT rate of leukoplakia, is thought to be about 8%, or about 1.5% of these lesions transforming to cancer per year. So if you sort of multiply the number on the second slide by the number on the first slide, you realise that the big meaning in OPMDs is in leukoplakia. Most of the other stuff is small beer. So when we get referred a leukoplakia, what we do in Liverpool, we work on a multidisciplinary clinic which is based in the dental school. And it's led by oral medicine, there's oral dermatologists, and I provide the surgical input and have done for over 20 years, and we have the support of specialist oral pathologists who look at samples we take for them. So of course we talk to the patients, we examine them, we're very careful to photograph these lesions, and we document everything, and we do biopsies pretty much uniformly. And after everything's been looked at, we end up actually usually with two outcomes. Either they're recommended to be removed surgically, or we keep an eye on things. Now, more latterly, we do have clinical trials we can put the patients into. And of course, if it's possible, we reduce risk factors, educate and inform the patients, and eventually decide when it might be safe to send them back to their primary care practitioners. And I'm sure we make lots of mistakes. So the laser excision of these lesions is as painful as it looks. That's just the removal of the epithelium and leaving the underlying muscle behind. And we use a carbon dioxide laser, a little bit of physics. And interestingly enough, what we tend to use these days is we stain these lesions when patients are asleep with iodine. And what iodine does, it stains for polysaccharides, so it stains glycogen, which is how most of our healthy cells store their energy. When we're looking at unhealthy cells, and these are dysplastic unhealthy cells, they stay white because they've used up all their glycogen running so fast. So the metabolic rate is determined crudely by this iodine. It's a very old test. And a colleague of mine from Glasgow ran a trial that we recruited patients to called LINCS, Lugol's iodine in head and neck cancer surgery, and found that the Lugol's iodine did actually help us to get surgical margins free of dysplasia. And I'll come back to why I mentioned that. But we're always trying to plug clinical trials, get involved to stop the pain. This is a new trial we've launched called Puribond as a way of seeing if we can reduce post-operative pain. But these are the results of laser excision. So this is the before and this is the after. And it's much better than the ugly slide I showed you before. I think I'm over with the gory slides now. And the tongue is somewhat scarred, but the patient does very well. The problem is it's difficult to demonstrate that the outcomes from surgery are as good as we'd like. There is some evidence it reduces malignant transformation, but there are reasons why not. So we're reluctant to prescribe surgery widely, not least of which is that 4% of the population have these white lesions, so we couldn't possibly do that. So the whole story about risk prediction becomes really important, is how we direct patients and stratify them correctly to be discharged from care, to have surveillance to keep an eye on them, where it should be, or to operate, or to intervene in other ways, maybe with clinical trials. So what we did is we approached patients and we set up the research arm of our dysplasia clinic 20 odd years ago to keep their data and their tissue aside and ask their permission to do research on it. And this is one of the early attempts. This is now 10 years old, but I think the data holds, where we looked for clinical and histological factors that predicted the risk of malignant transformation. And fascinatingly enough, the strongest risk is if the patient didn't smoke. You heard it right. If the patient is a non-smoker, the transformation rate is higher. It's because where we started is a patient with histologically diagnosed dysplasia. That was our inclusion, our denominator. And if you've got to the position where you've got an oral leukoplakia and you've got this dysplastic tissue, it's not normal, it's not cancer, this dysplastic tissue, without being a smoker, you're particularly high risk because there's an endogenous drive for it. But I can catch almost any medical and dental student out by asking this question. What I'm not advocating is that people start smoking to reduce their risk, because I don't know whether that would work. I presume not. But there are a list of factors, and interestingly enough, the histological grade from all the work our pathologists do on the samples wasn't predictive of transformation. There was a trend. In terms of how we use it, the data presented us with problems. So the first thing is that high-risk oral dysplasia, despite our efforts, was transforming in over a third of cases. So the patient would sort of say, well, that's, you're neglecting us. We've gone to you with a premalignant lesion and a third of us are getting a cancer. The other issue is that for mild dysplasia, what we were tending to do to that point is monitor the patient for about 5 years and then discharge them. Whereas the data showed that the risk started off quite low and then built. What we should have done is discharge them and then got them back after 5 years to monitor them. And you said that's a problem with getting data about your own clinical outcomes, is sometimes quite disconcerting. But there's another theme here about the nature of the problem, is that you may be familiar with Barrett's esophagus, and that's expensive to monitor, and people get annual endoscopies to look at their esophagus. And there's a 5% malignant transformation rate, whereas the lesions we've got in clinic, it's more like 25%. So it is potentially a real opportunity to intervene. And the things we're doing, and we've documented what we do, we can say what we do, they're not evidence-based, and in some eyes they don't work, even though we're probably the best we can be at it. So things have moved on about putting more clinical correlates through nomograms, and the best of the nomograms now comes from China, and you're able to put in certain factors and it'll tell you what the rate is. But I think they're fundamentally quite flawed. It would be quite nice to have something that was more reliable. So the priorities for research in this field are that histological grading, when we take a sample and the pathologist looked at it and tells us what to do, is not accurate. And we know that it's not accurate. The patients hate biopsies. And when we're faced with uncertainty, there is this gut feeling, particularly amongst the juniors, to do another biopsy. And of course, that's the patient really gets fed up with this when they've got these lesions in their mouth. And then there's a more direct problem, is that some of the fields that are affected molecularly and clinically are much wider than the area we've got the biopsy. We get a tiny sample, but what we want to know is what's happening to the rest of the oral cavity. And then the management is dictated by the decisions we made above. So we steer between over-treatment and under-treatment. And surgery obviously addresses distinct lesions, but the process can affect a much wider field. It causes scarring and then makes assessment of the area very difficult. And some patients literally have a mouthful of white patches, and it makes it impossible to resect. And then there's all the question about surveillance, which looks cheaper than surgery, but when you're offering surveillance in a multidisciplinary clinic with senior clinicians over many, many years, of course it's very expensive. And at some point you've got to make a decision about intervening or discharging. So, we get it wrong all the time. This is a patient with moderate dysplasia, a white patch. We might have easily recommended to remove it. We offered surveillance, and 4 years later, nothing's happened. If we'd have known that, we could have discharged them back to primary care and asked the dentist to keep an eye on them. This patient had mild dysplasia and subsequently developed several more lesions and 3 more cancers. And we should have been much more aggressive or invasive up front. So if we had better decisions, we would have better outcomes, I hope. And knowing that surgery isn't the only answer, I'm only going to mention it. We've got trials of interventions which are based around the science we do in terms of epigenetic reprogramming, topical therapies, and vaccine trials that we're developing. And these are the first prevention trials for oral dysplasia in the UK. So the aims of an improved diagnostic predictive device would be to have something that's non-invasive. Patients hate having biopsies. It would cover the whole field. Having a little 3mm patch assessed on the side of your tongue is great, but what about the rest of your oral cavity? It would be better if it wasn't dependent on somebody with my experience or my colleagues in oral medicine's experience, because there's only so many of us to go round. It would be better if something that would work in primary care, or even the patient could do. And there may be a trade-off between sensitivity and specificity, but accuracy is clearly important. Should this augment or replace our conventional risk prediction? I don't know. And there's also this issue that around about half of oral cancers start from these identifiable pre-malignant lesions, and the other half don't have lesions, but are the characteristics of the epithelium the same, and could they be picked up? So, this is where Peter Waitman and I started discussing this problem, and I did check before coming to the lecture. Our first email was in 2011, and it took us the better part of a decade to get a research grant. So there's something in there about the nature of collaboration and potentially how difficult it is, but we developed this, this work process where we got consent for our samples and we got a certain amount of information clinically, and then we worked with them through Peter and through Steve Barrett and James Ingham in their lab to try and sort of compare notes and to see. And the methodology they used was something they called FTIR. FTIR. I'm a bit embarrassed to ask, what is FTIR? I said, oh, it's Fourier transform infrared. I thought, well, I know what infrared means, I think. I do not know what Fourier transfer means, so I better go and find out. So Fourier was a clever chap, it turned out, and he was knocking around in France 200 years ago. And you always think that in the olden days they weren't as bright as us. They're probably a lot brighter, they were just less cluttered. And Fourier, amongst other things, worked out that the world was a warmer place than it should be, and discovered the greenhouse effect 200 years before it actually happened. But what the Fourier transform was, and this is where Steve's I'm going to get these looks, at which point I get this completely wrong, is essentially we used infrared spectroscopy and the absorbance of infrared through any material, and the Fourier transform converts this sea of numbers to a list of its constituent frequencies, which are then plotted against intensity to produce a spectrogram. So it's a way of getting an infrared beam absorbed and a detector into a spectrum like this. And this is a spectrum for the amino acid glycine, which is characteristic of glycine and looks different to the spectrum from other things. So that's what FTIR is. It's the combination of the mathematical trick with the infrared spectroscopy. And so what Peter's lab was doing in the most simple way is they had an infrared source, they had ways of altering its wavelength, they would pass it through the sample and have a detector. So why infrared? Well, they did infrared because what we're made of, and Peter's group was interested in the physics of life, interested in cancer diagnostics, what we're made of is organic chemicals, and they absorb light in the infrared spectrum. So this is a mock-up, and this is James Ingham's slide of the most simplistic version. And what they're using here is lasers of two wavelengths of light, and I'll come on to that. And this is the current rig, and James lent me this slide to show the two lasers on the left-hand side. And then in the middle there's this device to hold the sample and the detector, and then various devices to get a signal. So I think you'll agree this isn't a oven-ready clinical laboratory tool that could sit next to a doctor or even a pathologist. This is currently a Department of Physics research tool. But with this type of tool, what you're able to do is produce infrared spectra and then label them and ask questions like, can we classify benign and malignant disease? So is it that the spectra that are specific to cancer can be picked up? So you can produce, and this is obviously color-coded after the event, you can produce these spectra. These aren't sections that we're used to seeing as surgeons or as pathologists. These are different wavelengths from the same section, with these small differences between each section. So the infrared scanning yields a high-definition chemical map, and this is very much subcellular, and some of the techniques down to a 1 micron, which gives you high resolution, high sensitivity and specificity. And the way I think of this is in situ mass spectroscopy. It's non-destructive mass spectroscopy. It allows you to interrogate the nature of what's in a certain pixel, and the pixel can be as small as you like, down to about 1 micron. So is it okay? We'll start off with a fairly basic question as proof of principle. We'll take some lymph nodes from some oral cancer patients we've removed, and some of them have cancer in them, cancer metastasis, and some of them don't, and we know that, and let's see if the FTIR can tell us. And so what we could produce is scanning across small micrometastases, and we'd get change in signals, and these would correlate to things like nucleic acid. And we thought, well, that's interesting, because we know that DNA increases rapidly in cancer cells. And other molecular substances, perhaps we know not which, that would be able to characterize between cancer and non-cancer. So having proved that, was okay, let's move on to a real clinical application with a small sample set. So can FTIR predict malignant transformation in oral dysplasia? So first of all, we need a clinical cohort of samples where we know what happened. So somebody needs to have started 20 years ago collecting samples, getting permission to store them, and we have to know the clinical outcome of those patients. So we got a small number of patients, and we had transformers and non-transformers, and we're able to access their tissue and their data. In the physics world, this is a black box. You either got cancer or didn't. Keep it simple. In the real world, this is really difficult, because some of the patients misbehave badly. This one patient, 3287, had 9 events, 40 blocks, and some of these had candidal infection, which made the diagnosis uncertain, and it's all very messy. And actually, the work you have to do as a clinical side and a pathologist to try and simplify the story, so we've got one tissue sample and one outcome, isn't trivial. Even for 17 patients, it was quite a lot of work. Similarly, the physics isn't a black box. And we sell the funders the idea that we can produce a black box at the end of it, but currently things are quite messy. The principle, of course, is very simple. And these are the questions you have. How do you select the best wavelength that might distinguish? So our early experiments used a whole spectrum available, so they were very time-consuming and expensive to do, lots of data to analyse. And I was a bit shocked what Peter and James told me, but what they were doing is hijacking the whole university's IT at night to process their data from our 17 samples. They said, oh, well, one computer would take 150 years to analyse the data we've got, because they've got all these wavelengths from all these pixels, from all these sections, from all these patients. It's quite scary. So for certain wavelengths that you pick, you realise that the differences are somewhat subtle between the transformers and non-transformers. And it's only by looking at the global, all the data. But what was picked up very early is that you need a ratio of one wavelength to another. That would control the differences in the sample, difference in thickness, and would increase the ability to split out the transformers and non-transformers. And so by looking at all the spectra available, and this is early work, and this is from principal component analysis, we'd have our original histological slide, and this is our dysplastic epithelium and the underlying tissue. This is a colour-coded spectrum, and it's possible to fuse the two images and then supervise the analysis to look at what we call the suprabasal layers and the basal layers, which is where we think that most of the information about malignant transformation is held. So this clustering of data from the principal component analysis, from looking at all of the spectra, showed us that the weighting led us to 6 different wavelengths from this initial analysis. And so 3 were predictive that they're more likely to transform, and 3 were less likely. And if you pick those 6 out and find out what they correlate to, well, 4 of them are proteins and we don't know. 1 of them is glycogen. I thought, well, that was reassuring. And the other one is nucleic acid, and hence DNA. So we're getting some data from a totally unsupervised analysis, which fits with our understanding, our prior understanding of what might label transformation. So this method could classify malignant transformation with about 80% accuracy. So on its own, it's about twice as good as pathology. But it's under the supervision of pathology, because we have to point it at the right part of the section. We're able to identify wavelengths that provide the most discriminatory power. The hardware is burdensome. The data analysis relies on analysis of the whole data. And we can't go to the moon on 17 samples. So what we needed to do is develop a collaborative vision and a strategy to move forwards, to publish what we've got, and to get some funding to move things forwards. So the research strategy was for clinical validation. So we've got a cohort of around 300 patients with known oral dysplasia with consent. So we need to move from 17 to 300. So that's a lot of computer power. We need the device development, and the vision that Peter's group had was for the LDO1, the Liverpool Diagnostic Infrared Wand. So this is something that we can get behind and develop as a product, at the end of which might be investable and might need to be commercialised. Because at some point this needs to move out of the physics lab and into a diagnostic lab or into a clinician's hand, and that's not going to happen with the type of funding an academic group can get. And then to analyse this vast amount of data, we need a very mature machine learning element to this work to simplify. It just simply won't be possible to have all the wavelengths. We've got to pick key wavelengths. If you have 2 wavelengths, you have 1 comparison. If you have 3 wavelengths, I guess you can make 3 comparisons, and so forth. And the idea for this LDO wand, for now, is a slightly more sober idea than our initial ambition, which was to have a device you could use in the oral cavity and anybody could use. This is a device that sits in the pathology lab under the supervision and alongside a pathologist, and it relies on biopsies. So this is a stepping stone. So this is a diagnostic black box that will contain maybe 2 or 3 or 4 wavelengths of laser, and it will augment conventional pathology. It'll be like a slide scanner and give us extra information which might augment the decisions we're making. And of course, oral dysplasia is an exemplar project, and Peter's also working with other cancer clinicians, and there are other things, some of which will just replace what we do in pathology, and some will advance what is possible to do in terms of their ambition. The machine learning is really important because we need to work out which are the correct wavelengths to go with, and it's quite possible that these devices will have to be tuned for different clinical applications. And it's possible that one machine with 1 wavelength, pair or triple would be used for oral dysplasia, but a different one might be used for HER2 receptor status in breast cancer, and a different one again for a different. And so it's important to have the inbuilt controls and to get that data. And there's this process of training, test and validation that can be explained very simply, but uses, as I'm led to believe, phenomenal computing power. And by using now the machine learning algorithm on specific pairs of wavelengths, the diagnostic accuracy of the analytics is now higher than it was on our original paper from the principal component analysis, which analysed all of the data from all of the spectra. So this is what we put in front of our funders. And about 18 months ago, Peter and I got together and we thought we will have 1 grant that pushes the machine forwards, an innovation grant to the NHR for the IFI fund. And so the idea is we're going to construct a dual wavelength LDO wand, we're going to get some more data and move it on and have a commercialisation strategy. Simultaneously, we went back to Cancer Research UK and said, look, we need more samples. And really, we want to know which wavelength to use, so we need to purchase an FTIR machine, which is a couple of £100,000, and we need to sort of go back in and make sure we've got the right wavelengths. Using those, we'll then inform the design of the LDO1 for oral dysplasia, and then use that on our full cohort of 300 samples. And while we're at it, we might as well look at other epithelial squamous premalignant lesions in the lung and in the cervix. So the idea of this is to validate and develop and commercialise what we've got so far. There's some basic science questions as a discovery tool, is that these dysplasias are also being sequenced at the moment, and when we learn their mutational profile, will we be able to predict that or correlate that with the IR signature? We don't know. Obviously, there are other sites and pathologies. We're talking to the breast oncologist about molecular staging of breast cancers. If we're going to use this in oral epithelium, we need to do eventually, I think, some prospective clinical studies and how we're going to diagnose it, how we're going to design those. And as I said, at some point this needs to be taken into the ugly commercial arena, because there comes a point where university scientists have to let go, whether that's under a licensing arrangement or what. Not forgetting that we originally said what we wanted is something that was an in vivo device that didn't require a biopsy. That remains, a further developmental objective. So coming to the end now, some work that was done by Peter's group was to approach the big names in diagnostics and try and find out what they've got, whether they've got any competing technology, whether they're interested, and then to use this to form our commercialisation strategy. And currently, we're somewhere towards the beginning of this. But I think it's uncertain at what point we need that investment. Obviously, there's a lot of people involved in this, and not quite everybody made it onto this picture, but some of them did, and the sun shone, so we got a nice photo. And in the spirit of this collaboration between the Institute of Physics and the LMI, I just wanted to finish some reflections on the true nature of effective collaboration, because I think we tried ineffective collaboration for a decade before we landed on some funding and publications. So the lessons learned. Controversy over what clinical and technical validations are and what independent data points are. I think unless I said something, James and Peter would carry on analysing these 17 samples for the next decade. And I said, you have to move on. You've only got 17 data points. They said, no. We've got more data points than there are atoms in the universe. And I said, no, you've only got 17. And that tension is obviously a lively debate. But if you produce a clinical tool, we need to validate it on independent sample sets that are substantial, and we'll have to have multi-centre work. So these black box assumptions, I think, are essential. Sometimes you get out of bed and say, right, we've got all these samples to collate, and then they're going to go to physics, and their black box will tell us the answer. Fine, I can work with that. And they're thinking, yeah, Richard's going to send us these samples, and there's one sample, and there's a clinical outcome, and they don't want to hear about anything else. And I think they can be useful, but they have their limit, and eventually you have to respect the complexity of the other side of the problem. The importance of public and patient involvement, PPI, has become very important. This is Margaret, she's a patient, and she's been key to getting quite a bit of this funding. The funders will quibble about some aspects, and you point a patient at them and they say, well, the patient's priority is this, and here's the patient. And it shuts them up. And it's absolutely important. And, the value of patients who donate their tissue and their data, the value of mature, well-curated tissue and data cohorts. And it was a good decision to start collecting and invest a lot of my time in getting consent forms and ethical approvals 20 years ago. I didn't perhaps know why I was doing it. Our collaborations can produce grant applications that not only we can't understand, but also the reviewers can't understand. We can write papers that are very difficult to review. And what happens is an expert will only be an expert in either the cancer side of it, or the physics side of it, or the data and the machine learning side of it. But it won't stop them commenting on the other bits. And usually they'll focus on the other bits and be very critical of the bits that they don't understand. And I don't know exactly how you solve this problem, but we got better at it. And there was a key moment when we got some peer review back from Cancer Research UK, and they asked in detail about the physics. And I actually wrote the reply, because I said, no, these are cancer biologists. This committee is chaired by a cancer biologist. I can talk their language. And I think if you explain it in your terms, it will just go in one ear and out the other. And similarly, I think, understandably, the physics, the EPSRC aren't necessarily going to get clinical priorities. And so perhaps you have to produce a version of the paper and a grant that one of you has written, or at least everybody who's wrote it understands it, because these are very hard to review. We had interviews for our last tranche of funding. These aren't massive grants, but they were important to us. And in the interview for the device and the eye for eye, all they asked about was cancer biology, patient involvement, and how good our sample set was. So all the questions were directed to me. It wasn't my grant, it was Peter's. On the Cancer Research UK grant that I wrote, all they asked about was machine learning, because they didn't understand it. It's fascinating. There's this balance. Should we be saying we've got this ambition for a completely novel concept of a non-invasive diagnostic could be used in primary care in the third world? Or should we be offering something that's more proximate, a box that can sit next to a pathologist in a pathology lab that relies on resected samples, that's much closer to being able to develop? And I don't know. I guess it depends on who we're trying to sell the idea to. And I think it's still really unclear at what point to seek commercial collaboration. My spin on this is that when you stop getting grants, it's probably a time that you have to go to business and you're looking for the next level up for funding and lose control of it. And this business of how you license it and how that moves on is very uncomfortable to us as academics. But there's no point academics talking to ourselves in our own little closeted areas if it doesn't get into the real world. So I guess we'll have to confront that. And I guess to keep going, as I say, we've had a lot of emails and a lot of failed grant applications from about 2011 to about 2018-19. And then we've been quite successful in getting the next tranche going. And I think it was that convergence of ideas and purpose and the ability to keep going. And I'm not going to keep going because I've done 50 minutes. I was going to finish there. Thank you very much.